Is that centered now? No. I just went into presenter view. It's fine? Yeah, okay. All right, thanks for the intro. Yes, so this presentation is primarily around the research I recently did through my master's thesis at Murdoch, but it's essentially around mitigating falls risks amongst older adults. So it will be relatively quick as well as I just dive through what we use at the university, and then practice in private practice as well, and use some of these methods when assessing older adults who could potentially be at falls risk. So just quick about me, I started anatomy and physiology, actually finished Twin Chiro, don't hate me too much there, but then I went straight into evidence-based practice and did a master's in exercise and sports science, and got this driving interest around older adults' health and mitigating falls risks. We're now starting a PhD investigating further issues, I guess, around fractures, falls and bone health. So as I said, this research will be pretty much based off the investigations that we found back in 2022 actually, and we just finished up recently just trying to publish it. So functional capacity assessment is going to load. Cool. So functional capacity it refers to the individual's mental and physical capabilities to complete normal tasks of daily living. So throughout this, we'll talk about the biological aging, investigating functional capacity, mitigating fear of falling and falls risk, some methods to improve bone and muscle health, and primarily set the scene around clinic versus lab-based assessments, which functional capacity is traditionally used or assessed by functional assessments such as a chair, sit to stand, which reflects the individual's daily movements, such as getting off the couch or getting off a toilet, getting off a chair. So understanding functional capacity assessment, most of it's around the context of the individual who's in front of us, and what assessment is actually required. So for context, older adult that we use is classified by someone over the age of 65. So when working in private practice and working in research settings, it's always interesting to see who you have. You have these 65-year-olds who class as an older adult, but they're a marathon runner, or you get a 65-year-old who actually cannot get up out of a chair without their hands. So there's an extreme difference in their physical and functional capabilities. So throughout this, I'll be talking based on patients that I've seen in clinic and through the research. An interesting one that's come across recently, but it's the communication used to understand this and probably understand more of the context, but something such as the individual saying, I just fell over last week versus I had a fall last week. The two major different terms in the way that they explain what happened if they have a knee injury or why they can't do something. I'm curious to know, does this more so reflect age, the way they use these words? Someone might say, I just slipped, or I fell over. It's extremely different from someone who may put more severity on, oh, I've had a fall, which we'll get into talking about the fear of falling cycle, but just once again, in terms of context of the individual, their words or how they tell you a story is important. And back to the age 65 part, this is always an interesting image we come across, but it's taken out of something I read recently, but it's just looking at, I guess, sarcopenia, but more so muscle mass, and they took a cross-section of the femur, and they're looking at 40-year-old triathletes in comparison to a 74-year-old sedentary man, and then the 70-year-old triathlete, which I find pretty impressive if you're a triathlete at 70 years of age. But interesting to see those difference in muscular characteristics because they're using it a lot more. So we know aging's inevitable, it's bound to happen, but some parts could possibly be slowed, less progressive or modifiable. So things that will happen, we get a change in bone density, we get the muscles changing characteristics in strength, endurance and flexibility. This will lead to a change in coordination and stability and balance. Peripheral circulation may change, and sleep disturbances as we age. All these are internal factors, things that are biological inside of us that do change. This is not considering external factors such as footwear. But all these factors definitely do contribute to falls and fracture risks. So talking about the muscular characteristics, strength is a big one. Movements such as getting up out of a chair, lower limb strength, climbing chairs, hand grip strength, which is a lot more research around that topic at the moment, but opening a jar, getting up off the floor, picking up their grandchildren, just normal ADLs there. And then the next part's more about endurance and way an individual may say they need to rest while they're out. They can't walk as long as they used to. They're not confident to walk longer. They can't keep up with people younger than them. And then flexibility, just about those movements. Can they bend down to cut their toenails anymore? Can they sit on the floor? Can they get up off the floor? All of these characteristics lead to potentially greater falls risks and loss of stability and balance. We know this increases as we age. The big part of a fall is essentially a hip fracture. These are associated with significant mobility, mortality, loss of independence, and a financial burden. So the interesting stat is recently with 1 year mortality rate after sustaining a hip fracture has been estimated to be 25%. So this is after a hip fracture repair, not just a general hip replacement due to osteoarthritis, for example. With the fall, another one could be a fractured wrist just by bracing the fall as someone does come to rest onto the ground. The big part is a fear of falling cycle, where we get an individual who may have sustained a fall, and therefore because they had it, it's a psychological factor where they increase fear of falling again. Due to this, there's some deconditioning or lack of movement because they don't want to risk falling, and so they get decreased physical activity levels and then end up with reduced conditioning or decreased physical ability. Therefore, because of this lack of movement, they end up having an increased risk of falling again. A big part that I'm looking into now is around bone density and osteopenia and osteoporosis. But they're quite common amongst the older population and should be definitely assessed, I think, more regularly. DEXA scans or REM scans are now making a bit of noise, but these are methods where bone density can be assessed to see where an individual bone density lies, and most of the time it's from a referral from a GP, or in a situation where an individual has had a low energy, a low trauma fall that results in a fracture. That can also be deemed as osteoporosis. Someone with low bone density is significant increased risk of fractures. The bones become brittle and weak. Three major things that signs and symptoms that someone may say is they've had a sudden unexpected back pain from lifting a washing basket or from lifting something in general. You may notice more of a stooped or kyphotic posture and a reduction in height, but often the condition is rather silent until a fracture does occur. And then in severe stages, coughing could cause a rib fracture. Any other compressive forces can cause a fracture in the spine. Most common areas are the hip, spine, or wrist. So if someone was to fall who does have osteoporosis, either landing on the side and it can fracture a hip, or coming to rest on the buttocks and you get an axial compression to the spine, or they're bracing the fall with the wrist and putting the hand out. So just a clinical point, I see some of these patients, and this is an MRI, just looking at an individual, and he actually didn't even know she had fractured her spine. She just, she went to the GP for chest respiratory issues, and then they took an X-ray, and then they found out she had a fracture in her spine, and then investigated further for MRI and found she had a wedge compression fracture at T12 here. You can see how that causes that stooped or that kyphotic posturing, because the vertebrae is wearing away at the anterior or the front aspect of the bone. One more point, very clinical point, is that's the frustrating part with getting a DEXA scan to assess bone density, is that individuals aren't Medicare funded for a DEXA unless they've a few factors, but the main ones are over age 70 or had a fracture already, or other comorbidities, which is quite unfortunate because it's not more of a screening tool. It should be introduced earlier, around post-menopause age for females in particular. So we can mention all this stuff about muscular characteristics and falls and loss of stability and bone density changes, but the big thing I always like to refer back to is so what? So why do we actually care about this? Because we have so many interventions where there is RCTs for exercise. Tell an older adult to do some exercise, we know it's going to be beneficial for them. You know the balance is going to improve. We know the strength, if it's followed with a particular routine, it will improve. But how do we know which way they all work, or how do we assess who needs to be doing this? So we want to know more who is at risk to provide these interventions to, or another area of research I think probably more would benefit is implementation science. And so if all these exercise routines exist, we can identify the patients who are at a falls risk, why aren't older adults exercising? So what's wrong with implementation science at the moment? So the big so what is really that fall or the fracture, because that really leads to increased risk of serious injuries, fractures, head trauma, or even death. This can then reduce quality of life, dependence, more financial burden, impact on family, carers, requirement of movement aids, increase on that fear of falling cycle with other physiological, psychological and physical stresses. As I said, many interventions addressing intrinsic and extrinsic factors, exercise being one of the main one. So once again, how do we assess who is at risk? What is best to use as well? So on the left here, these are examples of technology advancements. So we've got accelerometers on the leg to assess someone's movement, and then a dynamometry machine to assess a variation of muscular characteristics, or traditional methods such as someone just standing up out of a chair, and we're measuring that with some simple tools like a stopwatch and a chair. So do we actually need these lab-intense calibrated equipments, or do we just need basic 6 square meters with a chair and to monitor someone's movement? So many of these assessments already exist. We know in laboratory settings we have isometric muscular testing, we have isokinetic dynamometry, we can measure endurance, torque, accelerometers, velocity and power during movements, but it's bound to lab settings such as a university or someone who has these types of equipment. So most of the time it is expensive, it's difficult to access, and if it's in a laboratory setting at university, most of the time it's just bound to study participants. Whereas in clinical settings, we can have a difference with practitioners' time or someone's appointment. We need valid and reliable tests, and then we need different equipment and environment to host this. In clinical settings, we might use tests such as a sit to stand, timed up and go, a 4 square step test, 8 meter fast walk test, or a 6 minute walk test. So just like the RCTs for exercise, all these assessments already exist. But what we want to know more in clinical settings is what is the best bang for buck, what's most time efficient, what's most feasible, what's most accessible. When comparing these commercial equipments, there's always external validation as well. So you might see someone with some of this big equipment, say imagine a West Coast Eagles player using an assessment for leg strength or muscular injuries, and then all of a sudden they're being assessed on the following week. There's going to be better buy-in from some of this technology because it's reinforcing with data and numbers compared to someone just with a stopwatch and a chair. So it does have a play on an individual's, buy-in to what you're trying to achieve. As I said, many of this already exists. This is just another example of those non-weight bearing exercises, non-weight bearing assessment, and then seated dynamometry. So we know there's a physiological decline in older adults, so those muscular characteristics we talked about, and it's well established as we age, there's a physiological decline, and it predisposes this population to increased risk of falls. This physiological decline significantly affects functional capacity, which can then, as we know, affect the quality of life and independence. We know functional capacity is the individual's mental and physical capabilities to complete these normal tasks of daily living. And the functional capacity is normally measured by functional assessments. So, as I said before, chair, sit to stands, or the timed up and go. The next part is talking about the outcomes. And so this chair stand test, such as a squat or a sit to stand, it's normally constrained to the number of times the tasks can be completed. And that's been traditional for the past many years and well established in research. So it's extensively used. You can have variations of it. So we can have a single sit to stand, or we can have 5 repetitions, or the number of repetitions an individual can complete the sit to stand in a 30-second duration. But now, because of recent technological advancements, there's other muscular measures we can assess, such as velocity and power and speed, just as important as strength, endurance, and flexibility. So due to these technological developments, it enables us now to precisely measure more of a performance. So movement velocity and muscular power, particularly of the lower limbs, is important for older adults to maintain and assess the functional capacity. So we know that speed of movement, velocity, for example, is one of the most important. So if an individual is going to fall, how quickly can they move their feet to regain their stance and prevent actually tumbling over? So if if we could measure this, it's important information regarding functional capacity. So measuring of velocity and power of movement during functional tasks was just previously bound to laboratory settings. However, due to this non-invasive technology such as accelerometers, we can now wear them on the forearm, such as this image here. She has it on her leg or on the chest. But it's not being comprehensively assessed amongst various sit-to-stand tasks and its ability to reflect functional capacity in older adults. It's significantly used in athletes. It's been used for other tests such as timed up and go, but other accelerometer-based metrics have not been validated or reliable. So validated referring to whether the measurement tool can accurately capture the concept it's intended to measure. We'll use this image actually, dartboard target. So it's that's for validity, whereas the reliability refers to the consistency of that tool and can it produce a similar result when used in the same conditions. So we would prefer it be both reliable and valid. So therefore we investigated as we do, and can technology be better than traditional tests during sit-to-stands, and can it tell us more? Ideally this is important. We want to know this for clinical settings where we have bound to appointment times, 15 minutes for 30 minutes or 45 minutes, and it's an individual most of the time paying for that time to be assessed. So these traditional tests already exist, as I said before. So 5 times sit-to-stand tells us about strength, and previously certain research tells different things, but if someone takes longer than 13.6 seconds to do 5 sit-to-stands, it can indicates a greater risk of falls. So these technological advancements can assess this velocity of the movement to further help us. What's unknown is whether velocity during those tasks are better indicators than laboratory equipment or the traditional tests. So that's what we set out to have a look at. So to break this down, we looked at older adults, so people above age 65, went through a screening questionnaire, and then we ensured there was no other orthopedic or unstable medical conditions, which is actually quite hard to try to find someone over age 65 without orthopedic limitations. But we screened for that, and then went through a familiarization process where we got consent, height, weight, and exposed them to these assessments, to these movements. They were then randomized into session A or session B. So everyone was familiar with the task they were going to be assessed on, which definitely made it easier. So we took them through a warm up, and then we used accelerometers on their body while they did a sit-to-stand task for a single, and then a 5, and then 30-second duration. Session A involved the individual going through dynamometry, where we assessed maximal voluntary contraction of the lower limb and rate of torque development, and then muscular endurance. And then session B, they went through the same sit-to-stand test at the start, but then they went through a functional testing battery, which involved a timed up and go test, 4 square step test, 6-minute walk test, and an 8-meter fast walk speed test. And then we statistically analyzed this. Must mention, since then, the technology we use has been acquired by another company called Whoop, which no longer exists. So our results are interesting part. So go back to the familiarization. It's interesting once the patient understands a test, how much better they get at the movement. So telling someone to stand up 5 times, they're always very hesitant, or 30 times. So the familiarization I thought was quite important, but nonetheless the accelerometers showed excellent retest reliability. So each dart made the target from the image before. So there was excellent retest reliability to assess velocity of the movement during the task. What we found was the velocity only moderately correlated with the functional testing battery, so all those other tests, and it poorly correlated with the laboratory equipment. Interesting enough, traditional measures of sit-to-stand, such as how many reps they did in 30-second duration, the time it took them to do 5, and the time it took them to do a single, it strongly correlated with the functional tests. And therefore, we sort of came to this conclusion that the accelerometer is a reliable measure of velocity during sit-to-stands, but it should not replace laboratory equipment alone or a battery of functional tests to determine functional capacity of older adults. But because of the correlation strongly with other traditional measures and the other functional tests, I think perhaps tech is good, it's great, but traditional wins there. So overall, I would say in a clinic or lab setting, whoever you're assessing for someone at falls risk, include something that assesses power, something that assesses strength, endurance, agility, balance, speed, gait. These are all things that we need each day that we use without thinking about it, but it can help us paint more of a picture about the individual. And really, so some of these tests, all you need is a stopwatch, cones, a chair, 15 to 30 minutes. In clinic settings with myself, we use other outcome measures for cognition. So we might use like a FRAT or a mini mental status exam. But in the physical measures in clinic, I think what I'm getting at is other physios, other exercise phys scientists, we can get a lot of information just by getting someone to do a sit to stand. So we could do a single, and how quickly can an older adult stand up out of a chair is a nice measure, perhaps of power. 5 times, it might tell us more about their strength. And how many reps they do in 30 seconds while adhering to good technique, can tell us more about endurance. So, to do someone for a single 5 and a 30-second sit to stand should take no longer than 5 minutes. Someone who has longer and wants to get more of a report or more information, then I do suggest adding in like a sit to stand, all 3 of them, the timed up and go, a 4 square step test, which assesses more functional balance, and then the 6, that should show the 8-meter fast walk test, and then 6-minute walk tests. So that's essentially what I was just saying, what to assess. You want to look at functional balance, agility, speed, endurance, and we use the ESSA guidelines here for these particular tests. Is where we got them from, but then we also looked at criteria for it. So they're well assessed thoroughly with ESSA, and they're used in many domains with EP and physios. I think the main context I was coming back to is about someone who if someone cannot do a particular test, then don't obviously put them at risk, or don't put them into that particular category, or just don't use it for now until you maybe can. For example, a 6-minute walk test is a long test and tells us more about maybe cardiovascular, endurance and respiratory health, but if they're going to fall, don't put them at that risk. Do something else, do a chair stand test. The criteria does change. There's many different, it's hard to find certain criteria, I must say, of what's acceptable and what isn't. You can see here from certain tables that I've extracted, it's, this was in moderately active older adults in a certain criteria, and this is the age breakdown as well. This is only for the 30-second sit to stand test with the averages. Haven't touched too much on this section, as there's said many different other studies for different parameters. And then, for example, a 5 sit to stand test, a time of 13.6 seconds or more could inform the individuals at increased risk of mobility, disability. Inability to rise from this is, I actually got this one from the Stay On Your Feet website. That's from the 5 sit to stand, but there is other articles that suggest different times or different variations for different age categories of an older adult. Because you can imagine someone who's 90 versus someone 65 going to have different scores. And same goes with the timed up and go tests. So identifying someone who is at risk of falling, I think it's important to record baseline data, even if you just want to have it as some sort of information, or if you're going to implement an intervention, and you can use it always to reassess. So if you've identified someone who might be at risk of fall because they can't get up out of a chair without their hands, or it takes them significantly a long time, that's important to know. So I would hold that as a baseline. In particular, this slide was about an individual I had who could not do that. He used to use that was a good old-fashioned broomstick there, but he used to use a walking cane to do it, and he would stand up using assistance of an aid there. And then you progress them over time use those RCTs that are out there, all the exercise interventions. Most of the time, just get them using assistance to pull themselves up out of a chair. It trains that muscular pattern, and they're able to do that. And then we reassess. So I might reassess there at 4 weeks, and then 8 weeks, and then 12 weeks to see if there are slight improvements. Because he went on to then challenge that, put some balance beams or a pillow, anything underneath the feet to challenge his balance, and then get up using primarily his lower limbs without the assistance of the upper body. And then add a weighted vest, something to help build his strength. And then more of a resistance here, so the concentric movement of him standing up, he's getting pulled back by the band, but he's also got weight in his hand. And then you build and you go further, a slight squat with a weight bar. So I think it's important, I've got his data recorded more on a spreadsheet. This is just one individual, but record that baseline of where you're at, apply an intervention, get them exercising, and then use those tests to reassess. And I used all of those sit to stands, the timed up and go, the 6 minute walk test, and an 8 minute fast walk test, and all these scores have significantly improved over the past year. So my final point is, I guess, always consider the context of the individual and what assessment is appropriate to them, what type of sit to stand, other functional measures that you need to use. You might just use one, or you might employ the whole battery of tests. But I don't think anyone's ever too young or too old to have baseline data recorded, and then get them exercising. That's what really reduces falls. We can always assess them, but even if they're doing some basic exercise for the lower limb and the upper limb, it's super important. And one of my favorite sayings I stole from a practitioner in the UK, who said, would your client rather be the oldest person in the gym or the youngest person in the nursing home? Which I always thought was quite interesting, and don't use it as not use it as scare care, but interesting perspective. That's pretty much it. So traditional tests won it for us, and that was the references, and that's my contact. I might stop sharing this now and give the floor back to Suzanne there. Cool.